is a short announcement.
Just one announcement from Gulati sir. There is a workshop of unicondylar knee at Apollo Delhi on the 13th of November. That's okay. So it's an information to all of you. So kindly register for that. Thank you. Thank you very much.
Good noon to everybody, and thanks AMC and Striker team to invite me and to interact with the AMC course. So having a too much knowledge, technology, robots and everybody, my talk is very difficult to find out what are the alternatives to such a high performing surgeries, and so I'll take you back to your OPD and trauma kind of things, so we can find alternative to TKR. So TKR is the most successful, almost predictable, promising and almost guaranteed surgery. Then why we need the alternatives? If alternatives, then what alternatives I can find? So it is a really big challenge to become an alternate than the orthoplasty. So I see osteoarthritis, if you see in your OPD practice, lot of the younger population is coming. Even your front desk and other workers, they have a 30 or 35 base, they come with the knee pain. So we cannot offer them the total knee replacement. So any reason which lead to the knee pain and osteoarthritis, maybe arthritis, where really we need to find the alternative. Even after such a progress of robots and everything, still satisfaction after total knee replacement or partial knee replacement, whatever other surgeries we are doing for the arthritis. So satisfaction is still 80 to 90%. Even at all the meta-analysis we see. So 10 to 20% patients are unhappy. Whatever if you are on table, you are very happy, I've done a good job and everything, but it is not guaranteed that your patient will be happy. So this is the most important reason that patient is still not ready to take the surgery immediately when your surgeon says. And fear of surgery and failure, it's very, very important, because one negative patient in your practice, positive patient may not do the good thing for you, because one is negative patient having failure and pain, he will keep on telling everyone, his relative and the society that no, this is bad surgery, bad surgery. That's the reason patients are reluctant to take the surgery. If TKR fails, then what? That next is the revision knee replacement made because of the infection or aseptic loosening or persistent knee pain, arthrophyrosis, whatever the reason. So next level is a revision total knee replacement, which is not exciting, costly, patient become behaviorally disturbed, morally depressed. So they are fear of the primary arthroplasty. Survival of the revision arthroplasty in the literature is 90% at 5 years and 75% of the 10 years. So again, revision is possible. Another fear is the natural versus artificial. Still many patients think that, yeah, I am going to get the artificial, so they are afraid to take the surgery. If there are options, then are too many options once you think about the other than the total knee replacements. So this is the preventive as well as therapeutic lifestyle modification. A patient like obese, which is nowadays very common because of the sedentary lifestyle and eating habits and stress that lead to the obesity and other problems. So we know each and everything about what is the lifestyle modification. These are the few very important aspect of the lifestyle is to say to if you are like a regular and chronic alcoholic or smoker, then to say no, and weight reduction and the regular exercises. Physical therapy, if you are acute attack of the arthritis, then it really helps. Walking aids on and off when needed. Other alternatives. Long list of analgesic and nutraceutics. Nutraceutics is a big market as well, because many people and many companies are coming with the claiming that yes, this is reversing the osteoarthritis and other things. So a long list, and every year you find a new nutraceutics. Pain management basically mainly used for the spinal pains, wherein a lot of nerve root block, facet block, but still in osteoarthritis there is a genicular nerve block with or without corticosteroid, but really for short term. intra-articular injection is, we see the most common in the OPD practice with the methylprednisolone, Kenacort or Kenacort hexa. Look at the literature, that is, results are not long lasting and it's short term is 16 to 24 weeks. And if you repeat the too many steroid, then there is a further loss of cartilage. Visco supplement can be another option, but really we look at the evidence, how it works. So visco supplement also having the mixed result and benefits are short term only. PRP is another popular therapy nowadays to claim that they really form the cartilage and reduce the synovitis. So you can use the platelet-rich plasma. So you extract your own blood and make it product and you can inject with a sterile manner. Short-term and medium results are like 6 to 12 months, and for long-term cure and the benefit is low in favor of low evidence. Prolotherapy is not very popular. It is injection of the 50% dextro in the joint, so it is also not recommended. That is a new theory which is coming, the adipose tissue treatment, SVF, popularly known as stromal vascular fraction infiltration. So it still need a more research and the more papers need, and after a long term we can say that yeah, it can help to early arthritis to delay the arthritis or the cure the arthritis. Collagen and the glucosamine, as per the literature, having the positive effects if you start the early treatment with the other therapies, so they can increase the longevity of the osteoarthritis knee. Arthroscopic surgery can be other alternative, but there should be a reason for the pain and the arthritis. If like there is a loose body or any meniscal tear or partial ACL tear, or one important thing I would like to say about the mucoid degeneration ACL. We 3-4 surgeons are making a group and doing the one study on mucoid degeneration ACL. Age group of 40 to 50 are having the high chance of mucoid degeneration and they have unexplained chronic pain. So if you do the arthroscopic ACL reconstruction, they have very good results. So that could be, you really look out at the clinical and the MRI finding. Focal cartilage defect can be treated by the arthroscopy, by the ACR, or there is a new product of Cartifil, so you can do the Cartifil treatment. Arthroscopy debridement was, it's a disputed process, we should not do. Rather, it increases the pain later on after the arthroscopy debridement. I see another option is knee osteotomy, which can be considered for the patient is not willing for the arthritis, total knee replacement or partial knee replacement or other definitive treatment. So there are high tibial osteotomy, which is the medial and lateral type of the osteotomy, dome osteotomy, SCO and DFO, which is distal femoral osteotomy, can be considered according to need of the patient. So ideal patient of the osteotomy will be age less than 65 the male and less than 55 a female, intact lateral compartment, normal range of motion, or BMI should not be very high. Contraindication for osteotomy is the correction needed more than 20-degree flexion contraction, knee flexion more than 90, knee flexion, range of motion is less than 90-degree, tibial subluxation, inflammatory arthritis, patella bow and medial compartment tibial boneless more than 3 millimeter, and morbid obesity. Pre-operative evaluation is very important for all the hip, knee, spine, ligament and stretching X-ray, scanogram, MRI. Planning is very important to take the osteotomy, patient selection, deformity and amount of correction and implant selection. So you must need a proper imaging first to taking for the osteotomy and correction of the weight bearing axis. There are open and closed wedge osteotomy, you know each and everything about the osteotomies. So aim of osteotomy is to restore the mechanical axis line, this Mikuluk's line, and maintain the joint congruency angle of 0 to 2 degree and maintain the LDF and MPTPA. This is the most important angle which we should know before taking the osteotomy. So that is the Fujiwara point, which is a point 62.5% from medial to lateral width of the patella. It is just lateral to the lateral spike of the spine. These are the few angles which we should know before taking the osteotomy. This is the most important slide where we need to correction in the osteotomy. This is MPTA, LDFA, JLCA. It is if MPTA less than the 84 degree and LDFA more than 90 degree, then yes, you should go for the osteotomy and you have to create the JLCA 0 to 2 degree of the correction. Correction in the sagittal plane is also important. If your ACL is deficient, then you have to decrease the tibial slope, and your PCL is deficient, then you have to increase the tibial slope. This is a technique of the medial wedge open osteotomy. You can go through the AO website. So I'm not going the detail because everybody knows. So a 42-year female with diagnosed with early osteoarthritis. So we have taken the consent, and after thorough counseling, we have done HTO, and good alignment and patient is good. Like case 2 is a very 36-year female. So what to offer in this case? We have done the osteotomy. Another 48-year male driver, which is do not want any kind of the implant surgery. So we have counseled and done the surgery. I don't know how it's working. So good range of motion after that. Without varus thirst, he can walk. No varus thirst. And he has a good experience. So if you select the ideal patient and counsel them properly and tell them that you may need a future surgery, so it can be a good option. Another 41-year of male, another 55-year female, not interested in TKR. Thank you, AMC.
So thank you so much, Dr. Ishwar. And I think the theme of this session should have been what God gives you is always the best, what man gives you is second best. So preserve the knee wherever possible. And I think all our speakers have helped us improve our indications and given us wonderful technical tips of doing the surgery better. So I conclude this session with these concluding remarks.
Wonderful lecture. My question is, the similar indications of other modality like a high tibial osteotomy or a unicondylar knee, almost similar. And I preferably, and most of our learned audience are more aware of high tibial osteotomy in our scenario in Patna and Bihar. So what your opinion, the unicondylar knee or the high tibial osteotomy, which one you like most?
Sir, if you are not, very good to do like unicondylar, then osteo is the most salvageable and most predictable surgery, because you see, look at the literature of the partial knee replacement, even nowadays coming up like HP sigma and the fixed bearing unicondylar. I have done many HP sigma also, where you're really not worried about the ACL, because limitation of Oxford is to every time you have to see about the ACL to need a lot of MRI and X-ray, and it's technical demanding. Oxford is really demanding. But you look at the Johnson HP sigma, it is very easy. And you really not bother about the, all these technical parameters of the unicondylar. But unicondylar has its life. So in my early practice, I have done almost 10 to 12 partial knee replacement, but they are working well till 8 or 9 years, but they still, now they are starting having the pain and varus collapse, so we have to revise. So we should clearly tell them that this surgery is only to make to avoid the total knee replacement. You might need the total knee replacement after maybe 8 year, 10 year, 12 year, your luck. And as young the patient, you will need, your survival will be less of the implant. Your elderly patient after 65 years, uni is very good. So STO is, I was really scared of doing STO, but nowadays I studied because I'm getting more younger patient, like 36, 41 year of age. Really, I hesitate to do the total knee replacement. If I have the problem like in the my knee, and I am still less than the 50 year of age, so I would also like to go for the STO. Our SMS professor, Dr. Rakesh Bhargav, he won't opt for the total knee replacement, and he's doing well since I have seen more 8 or 9 years more. He gone through that that SCO with the external fixator kind of the osteotomy.
So it is the end of the session. It was quite informative and quite attractive. Thank you. Thank you to you all.